안녕하십니까, 김경호입니다.
Greetings, I'm Dr. Kim Kyung-won. Today, at times, we need to remove implant after having provided implanted treatment and prosthesis delivery. At times, implant can be fractured or due to severe peri-implantitis, implants need to be removed. When implants need to be removed, how should we do it? I'm going to share my clinical cases as we discuss upon this topic. We can use trapine burr or high-speed burr or elevator. You can also use EFR kit and other special kits to remove implant. I'm going to talk about these using clinical cases. Removing implant. The necessity arises when there's destruction of surrounding alveolar bone of implant like peri-implantitis. In this case, you need to remove and replace it. At times, unfortunately, implant can fracture and implanted position can be unfavorable as we go through prosthodontic phases. At times, the internal structure of implant could be damaged, leading to inability to connect to superior prosthesis. There are these 4 causes. It's very unfortunate if you need to remove implant. I'm going to talk about clinical cases and address upon these. I'm going to focus on clinical cases. If necessary, you can go to DenAll and go into Doctor's Tip, which is an easy hands-on site. There's videos of how to use ESR kit and EFR kit. They're done by myself. You can refer to them. Today, I'm going to talk about clinical cases. I'm going to talk about removing implant using trapine drill. If you look at this case, in 2013, on both sides of lower posterior, number 36, 37, 46, 47, 4 teeth are missing. The bite force was strong and angle was developed. The masseter muscle was thick. I recommended placing at least 2 implants on both sides. However, due to economic reason and other factors, the patient only wanted 1 implant placed on each side, 1 on lower right and lower left. In 2013, it was lower posterior. I used SS3 tissue level implant of 4.5 by 10 millimeter on number 36 and 46. This was how it was placed. The patient was using it well. After 3 years of loading, the implant on the left side fractured. Implant had to be removed. After that, 2 implants were to be placed. I recommended placing 1 more implant on the right side to prevent such catastrophe, but the patient only wanted 2 implants on the left, number 36 and 37, and Botox injection was to be done on the masseter muscle because the bite force was strong. Implants have been placed like this. I considered using EFR kit when I removed the implant. However, it was difficult to do so. Trapine drill was used. Trapine drill was used to remove the implant. You can see that it was difficult to place the implant right away due to severe alveolar bone destruction and heat generation. I decided to wait approximately 3 to 4 months after healing to place the implant. You can use burr or other tools to remove the implant. In this case, approximately 2 years ago. The patient received the implant placement in number 36 and 37 from a different dental clinic. On the cephalo image, the two implants are placed too close. This is external connection type, and you can see that abutment is not properly placed. So prosthesis is improper. The patient complained of severe pain. Since implant placement, the patient was unable to eat properly. There were constant inflammation and problems, and the patient was referred to me because there was really nothing to do. I thought we needed to remove it because the pain was in pain. If you look at oral cavity, the gingiva was always swollen and gingival retraction occurred and implant surface was exposed. It was very difficult to remove it. When you open flap like this, the implanted surface is already exposed to the thread and there's a lot of alveolar bone destruction. There were issues with the prosthesis themselves. Flap was reflected, implant was removed. There's not enough space to use trap-line drill because there's too much bone destruction. In order to minimize bone damage, I used a Fisher burr to remove the implant. You can see significant bone defect here. The implant itself was osseointegrated nicely, therefore it was very difficult to remove it. Implant was removed. This is right after. This is 3.5 months after. CT was taken. When CT was taken, fortunately on the lingual side there was a bit of bone left, but you can see that there's no buccal bone left. Surgery was done again. The implants were placed with sufficient distance in between. The thread was quite exposed from the patient's ramus. I took block bone and did graft. Xenograft was used and fibrin glue, which I like, was used. The collagen membrane was used. GBR was done. A second surgery. Compared to the exposure initially, you can see that favorable results have been achieved. 6 months after secondary surgery was done and prosthesis delivery was done. Screws used to fixate the block bone were left untouched because I thought removing them could cause other issues. This is 3 years after second surgery. The patient is using it well. If you place implanted too close to each other, you can use a Fisher burr to remove them. As for this patient first came in last year. Number 16 and 17 were missing. The surgical video is on dental site. CT was taken. The sinus itself, ostium, is not destroyed, but bone height was okay. Therefore, one cast was used. 2 implants were placed, engaging the sinus floor. Implants were placed nicely. Prosthesis delivery was done. After that, as we were doing this, the implant on the other side fractured. This implant was not placed by my dental clinic. The implant from company S was fractured. The patient came in confounded as to what to do. I took CT once again. The fractured implant was quite buccally inclined. The diameter was 4.1 millimeter. Because this is quite a thin implant to do a single implant in the posterior area, it was buccally inclined. In order to remove the implant, if I were to use trap-line burr, then there will be too much destruction. So I paid attention in preserving the buccal plate as much as possible as I removed the implant. I planned the implant to be placed more palatally. If you look at the buccal plate, I tried to preserve it. I used a high-speed burr on the mesial and distal side of the implant to remove it. It was more osseointegrated than anticipated, so it was not easy to remove it. There was bone on the palatal side, so on the same day, implant was able to be placed. On the front side, there's still a buccal plate. In the gap, allogenic bone was used for bone graft. Collagen membrane was used to cover the site. This was how surgery was completed. This is post-op panoramic image. You can see that implant has been placed nicely. Fractured implant was removed. This is post-op panoramic image. The fractured implant was more buccally inclined. After it was removed, the implant was placed in an ideal position. TS3 5.0 by 10 mm implant was placed more palatally. As you can see, allogenic bone was used on the buccal side. Compared with the fractured implant, the implant has been placed more palatally in a more ideal position. There was still some bone, so I was able to place the implant. This is after 4 months at second surgery. ISQ value was 80 and 85. Prosthesis was delivered, but I omitted the image, so I apologize for that. The healing occurred nicely without major issues. This is at second surgery. You can see the buccal bone is maintained because we did bone graft. I'm going to share a case where I used the EFR kit to remove the implant. The patient received the implant from private clinic at the time of implant placement. The dentist who placed the implant referenced number 7 on the distal side, so the thread on the distal side of number 46 was exposed significantly and the patient wanted to replace it. Loading was not done on the implant itself. Healing abutment is connected. EFR kit was used for removal. I used the EFR kit for implant removal, and therefore I was able to place the implant with same diameter. If I had used trapine drill, it would have been more difficult. In the case of lower posterior, somewhat level of osseointegration did occur because it has been some months since implant surgery, but if you use EFR kit, you can replace it easily with the same size implant with EFR kit. You can place implant with minimal damage to surrounding bone. Torque wrench was used and it served a similar role as EFR kit. When the patient first came in, another dentist placed the implant in number 14 and 15, but the dentist was not able to place in number 16. Lateral approach was requested along with sinus graft. In number 26, because of the wide implant, inflammation continued to occur. Therefore, the patient required additional attention to the upper left once upper right prosthesis was delivered. Sinus graft was done on upper right. OCSB was used for bone graft. After 1 year and 10 months, so almost 2 years, in the area with wide implant in the upper left, there was continuous peri-implantitis. The patient came in for removal. When I opened the flap on the buccal side of the wide implant, it is fully exposed. I used a torque wrench to remove it. I think I could have used EFR kit. When you remove implants, the torque wrench itself, the torque in the general implant kit, it is about 100 Newton, but the torque wrench in the EFR kit, you can apply up to 400 Newtons. Therefore, if you use torque wrench in the EFR kit, it will be easily removed. After that, cast drill was used for sinus lift. The xenograft was used and GBR was done on the exposed area. Bovine bone, AOS was used, casket was used for crestal approach, and surgery was done as shown. It was removed in the case of sinus, in the case of upper molar. Even though the patient used the implant for several years, you can use EFR kit or torque wrench to remove the implant, even though it was loaded for several years. The surgery was done. You can see that the follow-up was done nicely. The bovine bone graft placed with casket is well maintained. It's approximately 5 years after. We removed the previously placed wide and thick implant and placed the SS implant, and follow-up was done nicely. As shown on the left, OCSB and AOS was used for bone graft. On CT, there is no major problem during follow-up. Let me summarize. Today, I have talked based on my clinical experience. I did not talk about EFR kit and ESR kit. If necessary, you can refer to it on the dental site. Based on my clinical experience, in the case of upper, in the case of implant where loading did not occur, even though if loading was done for some time, you can remove implant with EFR kit, even though osseointegration occurred. I used to use strapline drill in the upper, and now I believe EFR kit would suffice in the case of upper. In the case of lower, if loading did not occur, EFR kit can be used. However, if osseointegration occurred and if loading was done, there are some cases where it is difficult to remove the implant using EFR kit. In that case, you can remove the superior portion using trapline drill or bore, and you can use EFR kit after that. In other words, you can use other tools in conjunction with EFR kit. Simply put, in the case of upper, you can use EFR kit to remove implant easily. However, in the case of lower, if loading was done, there can be difficulties, so supplementary tools need to be used. This was a brief lecture, but I hope by showing you some of the cases I've done to remove the implant, you were able to get a sense as to how to approach the situation for implant removal. Thank you for watching.